would also tend to be very important for somebody that potentially has had a long-standing UFR lesion. Because what we can have is we can have a UFR with an underlying capsular pattern. Okay, that happens a fair amount. What does that look like? We go through and we do our UFR assessment. It would look like a UFR, right? We would do our manipulation. We would come back to re-examine our ranges of motion. We would still have loss of motion into the fadir position, and we would still have a loss of internal rotation. The difference now is you're running into a capsular end field as opposed to the pathomechanical end field you would get from the UFR itself. So end up using this, certainly at least I do, end up using these arthrokinematic glides, singular, quite often, multiple times per week. So basically, all we have to do here, I usually bring a patient up into, kind of almost a resting position here. So the hip is in about 70 degrees, 65, 70 degrees of hip flexion here. And then all I want to do is produce a straight distraction moment. Okay, so we're following along the line of the femoral neck, away from the acetabulum, right? Typical acetabulum will face anterior and lateral, correct? So from there, I'm just going to fixate the knee. I'm going to get as close as I can to the superior end of the femur. And all I'm going to do is just produce a lateral distractive glide. Right, now, how am I producing this? I'm just leaning away from it. So, fix my elbows, and I'm doing this with my hips. Right, I'm not pushing through my arm. I can do this with my hips all day long. Doing this with my arms is going to wear me out pretty quick. Okay, so that's one method. The alternate method, and sometimes I'll switch back and forth between these just to give myself a little break, is coming here, again getting as far superior up the shaft of the femur as we can get, anchoring my elbows toward my side, and then I'm just going to lean away. Again, using my hips to produce the distractive force. Okay, so I might spend a couple of minutes stretching in that position, swing back around, stretch in this position. Essentially, I'm doing the exact same thing. Just gives me a chance to stand upright, give my arms a little rest, shake them out some. Occasionally I'll do this sort of thing here where it's just kind of moving the joint around a little bit, more for my benefit than it is for the patients. Yeah. I mean, I've spent entire sessions, 20, 30 minutes at a time doing nothing but this on patients. Yes?
Do you do this with a belt by any chance? Or how do you?
I don't have a belt in my clinic, so I just use my arms. You could use a belt if you'd like. Yeah, there's nothing wrong with that. I just didn't bring one to my office when I opened it, so don't have one there. Any questions about that? Now, a lot of times when I have a patient come in and they have a substantial capsular lesion here, a lot of times this will be an older patient, this will be somebody that's had a long-standing UFR lesion. But these are things that they don't feel like they're going to move very well. You got to give them something to where they can kind of work on this at home. Because coming in to see, typically my patients only come in to see me once a week. So coming in to see me for, even 40 minutes or an hour once a week isn't going to be enough. Frankly, I don't want to spend a whole damn hour just doing this. That'll get pretty tedious pretty fast. So the thing that I use is I will ask them to get a hold of a looped TheraBand, right? These are the things you can buy at like Dick's Sporting Goods. They're just home exercise implements, right? So I'll ask them to get a hold of one of those, relatively heavy resistance, and then we'll have them anchor it to something that's not going to move, right? A banister. You can anchor it to a door. You can anchor it to something, anything that's not going to budge on them, right? You want it probably about knee height to start out with. So what you're going to do is you're going to loop it around their leg, right? And you're going to put them in a genuflected position, right? So if I anchored it to this table, I would want to step out laterally here to put them into a genuflected position. Well, it'd be this side, right? So the front leg would be the one that I'd be tractioning. And you just have them sit in that position to allow the band to produce the traction for them. So typically, you've had relatively decent success with that, assuming that they listen to the recommendation, perform the activity, and get a heavy enough band. I've had patients complaining, like, it just doesn't feel like it's doing much. I'm like, okay, what color is the band you got? Oh, it's red. Yeah, the red ones are the really thin ones. That's not going to do the job. You need like the green one that's like this.
How long do you have them hold it for you? Is it on?
I ask them to try and hold it for at least 5 minutes. The only thing they really have to do outside of getting in the position is just hold their knee in place. Because the band, because of where it ends up being, will tend to try and pull the knee into abduction. So they just have to hold their knee straight ahead of them.
And are they in the half kneeling position that you just showing?
Yep.
Yeah, and what if they cannot kneel?
Well, you can do it in different positions, but what we would really like to do is we'd like to keep the joint capsule relatively slack. So in the rest position here is the best. I mean, in fact, even coming up into 90 degrees with that genuflected position isn't ideal. But there's you just have to find a way to get them in a spot where they actually still can get traction on it. It's gonna be harder to do. You could do it in standing, in theory, but again, you're gonna have more muscle recruitment in standing than you would in that genuflected position. So you might need to put their knee down on a foam pad or pillows or something of that nature. That would limit the amount of hip flexion you'd get and drop the knee down. So, but that's really it, guys. That's the biomechanical assessment and treatment of the hip.